So with that in mind, I call this meeting to order at 12:30 on July the 23rd, 2015 for the Board of Health. Roll call, starting with Torney, please.
Torney Smith, Spokane Regional Health District.
Susan Norwood, appointed member.
Bob Bless, appointed member.
Ann Pitzel, recording secretary.
Michelle Fossum, legal counsel.
John Snyder, City of Spokane.
Keith Baldwin, appointed member.
Chuck Hafner, City of Spokane Valley. Now let's start back with Elaine, please.
Elaine Conley, special director.
Is there something special happening with you? Is there something specially happening down the road with you or regarding you? Nothing?
Just a little retirement.
Just a little retirement. You'll thoroughly enjoy that, so that's great. And I know that from my point of view and the board's point of view, we want to thank you very, very much for your service. And we'll have the opportunity at your reception to say some of those things, but thank you very much. Okay?
And Kyle Ludland, Division Director for Health Promotion.
Okay.
Mark Springer, Epidemiology.
Katie Anderson, administration. Linda Graham, health policy and communications manager.
Okay.
Julie Aubrey, providers fees and special projects for the environment and environmental health.
Did she do all right?
David Swank, her boss. David Swank, Director of Environmental Program.
Okay.
Kim Gray Marsh, county manager.
Mike Riley, the comptroller. Ray Byrne, food program, environmental health.
Heather Wallace, Community and Family Services in the Universal Developmental Screening Program and in Neighborhood Center.
Okay, thank you very much.
Oh,
Oh, I'm sorry. I do that every meeting. I forget somebody.
I'm the program manager for the Infant Child Network and access to baby and child dentistry and the Apple Health Project.
Okay, thank you very much. Due to the fact that there is no one here for citizen input, is that a record? After 16 years, I think that's a record.
Don't nix it.
Oh, I don't want to nix it. No. Okay. Well, we'll continue. Okay. Chair report. First number of things as we some governance committee. Do you want to talk about the governance committee, Keith, about what we met?
No, go ahead.
No. I'll leave that up to you. You're the chair.
Well, the governance committee did meet. Governance committee did meet, and we talked about sort of progress to date on changes that we had asked the board to consider. And I think we're going to do a few more things with education and maybe get some feedback from some other committees like policy committee and others to make sure that the changes that we have accepted are working for us. Evaluations. I didn't know we were ready to bring that up, but
We're going to do it end of the year.
okay, end of the year. It's only July.
And it'll go very quickly. He'll be saying, "Oh my gosh, it's the end of August now." So.
But thank you, Linda, for all your hard work and helping us remember.
I do want to remind the board members that you do have an emergency card in your packet. They've been updated for your information. Also, the Board of Health and Executive Leadership was interviewed by a consultant by the name of Rick Kramer from Organizational Resource Group, and he is helping executive leadership with organizational development improvement. And Torney will explain more of that in the health officer's report. Is that correct, Torney?
Yes.
Okay. Also, just a reminder that our next meeting will be September, and help, what is it? 24th? September 24th, for your information. Also, the Board of Health meetings are typically broadcast the Tuesdays 8 p.m. and Wednesdays at 10 a.m. the week following the Board of Health meeting. So if there's, if you'd like to watch all of us in action, and need to spend some time, if you want to have what do I, comical hour? Is that would be put it right? No, that's not true about us. With that, I think, Torney, you're on. Please.
Thank you and good afternoon. On behalf of Dr. Joel, I'd like to cover a few items that he wanted to share with the board. To begin with, to reinforce what Chuck had just mentioned, Rick Kramer with Organizational Research Group is here, has been interviewing many of you and the executive leadership team, looking at outgrowth of our strategic planning work, which is looking at organizational development. And what organizational development is, it's actually a field of research and theory on dedicated expanding the knowledge of how organizations can accomplish more through the effectiveness of its people and changing performance of that system. Dr. Joel is the sponsor of this effort for the undertaking that we're doing. And the areas of focus will include leadership, teamwork, and enhanced communications. And as you know from your visits with Rick, he has begun to encapsulate a lot of information from all of us that he will be sharing with Dr. Joel. We will be looking at a later date for a retreat where we sit down and work through all of this. So more information will follow as that moves forward. Secondly, wanted to identify that there has been a recent rabies exposure, a 7-year-old little girl who was bitten and her mom who was scratched. And if the board has questions or wants more detail, Joley Aubrey is here who can fill you in on that, as well as mosquito pools in the state that have been identified to have West Nile. So if you have any specific questions, Julie can answer those. Otherwise, I can move on.
Any questions? Okay, John?
It's a statement, not really a question. I thought the information about rabies got out pretty good, the news media. One of the reasons I don't have questions is because the health district must have done a pretty good job of getting that basic information out there, because it talked about, there was some detailed information about bats and about some of the nuts and bolts of rabies. So it's good work.
Great. Well, kudos to Linda and her group.
I think we all agree with that, yeah.
Also, there has been an uptick in pertussis. We have quite a jump from last year, and Mark Springer, epidemiology, is here if you have questions about any of the pertussis increase in the states. John?
I would be interested in just a few more details about any ideas about why we think that's happening.
Great. Mark? You want to?
Part of the reason why we see...
Yeah, I think if any of them, yeah, this is probably best.
There are several reasons that we're seeing an uptick in pertussis at this point in time. Part of it is that the disease is cyclical. So every 5 to 7 years we see outbreaks. That tend to be pretty large in scale. The other thing is that with the vaccine, since we've switched to the acellular pertussis vaccine, we've seen fewer side effects with kids with vaccination, but immunity has not been as long-term. And so that's why we have the Tdap vaccination in place for adolescents. And so part of what we're seeing is just the natural cycle of pertussis. At least locally, what we're seeing is a lot of activity with younger children. Not so much school age, but more daycare age children. And so that's kind of what's happening with the local epidemiology. But we're starting to see an uptick in cases over the last probably 2 months. And I think the state has preceded us by several months before that. Yes.
Mark, what about adults? I mean, probably over the last month or so, I've seen pretty consistently adults coming in with, the constellation of symptoms that starts off almost like an allergic cold phenomenon. Mm-hmm. Rapidly moves sinuses, sore throat, and then cough. And typically the cough is lasting 2-3 weeks. I mean, yesterday in clinic I saw 3 people. And, current with immunization status, one person had been on 2 rounds of antibiotics, no symptomatic improvement. I mean, are we seeing adults with this in this uptick as well?
We are, and most of the time that we see adults with that type of clinical picture is when we interview families with children who are diagnosed. Children have more of the classic symptoms, and they're going to get more symptomatic. And so we'll often see adults who have kind of lingering coughs that's been there for 4 to 6 weeks, but they're not sick enough to see a doctor, or their symptoms are too mild. And so that's a concern for us, because that's our reservoir, is adults and adolescents who have milder symptoms who are transmitting this in the community, and then as a consequence we're seeing more testing in young children.
But again, I would say that, of the people I've seen, Mark, I would say that the majority of adults I've seen have not had children who have had respiratory illnesses. And so for me the question has been, do I test these people for pertussis? If they're not, again, if they're still coughing, do I treat them empirically so that they're no longer contagious?
We do recommend providers considering pertussis as a diagnosis in either testing when you have a cough illness that's went 2 or 3 weeks with that's not typical of a allergy pattern, or another COPD or something else that's happening. We just don't see a lot of testing within the provider community with that. We see a lot of empiric treatment, and we hear about that. People are getting treated for that with a Z-Pak or so, but we look at all the testing that we have. Probably of our cases, I'd say probably about 80% of them are children.
Can you speak up a little bit?
Oh, I'm sorry. Probably 80% of the children, or the people that we get diagnosed with pertussis at this point, are children. We don't get a lot of testing in adults, and we don't have information in terms of the number of adults that are tested. We only get information on people who test positive.
Any other questions?
Actually, Mark, I will ask you one question, sort of tangential to this. Last week, one of my colleagues diagnosed flu at one of the clinics. So flu in July?
We have had reports of some influenza B in early July. Nothing in terms of hospitalizations. We've had hospitalizations for influenza B in June of this year, which is unusual. Usually we get our last hospitalizations reported to us sometime in April or May. So we are seeing a little bit longer flu season with influenza B, and we have gotten some sporadic reports from provider offices, but the only system we have right now in place for case-based reporting is with hospitalizations, and our last one was in June. You're welcome.
Thanks, Mark. 2 other things I wanted to share with you. One is a presentation that I had the opportunity to attend at our national conference 2 weeks ago, and it was about an occurrence that happened in Indiana, in a smaller county, Scott County, a city of Austin, and the city is about 2,400 people. They had, in a relatively few months, an outbreak of HIV, 155 cases. And the epi work on that determined that it was because of the sharing of needles, because of opiate addiction. They identified there as well prescribing challenges that they face, as is true across the country. There was a physician from the Indiana Department of Health, Jennifer Walthall, who did a presentation that was very, very moving about the political environment and the social acceptance of both HIV and opiate use and addiction that exists in this country. And it made me feel incredibly proud that this community looked forward literally 23 or 4 years ago and approved a needle exchange. We have also had our opiate treatment program, which now has in excess of 630 people on it, with a waiting list of a couple hundred. So I think as a community we have been aware and been willing to address the issues. What I have learned is that this outbreak in Indiana is costing that county approximately $100 million. So kudos to this board and to this community for having some foresight and understanding what we need to do to control disease. Finally, I want to follow on with Chuck's earlier comments in recognition of Elaine Conley. Elaine came to us in April of 2007, so a very brief 8 years. They have just breezed by. I certainly look at Elaine as a person who has demonstrated sound leadership, courage in what she has chosen to do with her programs, been innovative. Neighborhoods Matter, which you all know about, Weaving Bright Futures, the focus on ACEs, really has been under her leadership. And I have really treasured working with Elaine over these years. You have all received an invitation to attend on the 30th from 11:30 to 1:30, a retirement party that she is hosting. Not spending those public dollars. Typical of Elaine. So certainly want to acknowledge what you have contributed to this community, to women and children's issues, the support of public health nursing. A real loss to us as she moves on to retirement, and we certainly wish you well.
Would you like to say a few words? No? We'll hear those at the reception, correct? Thank you. Anything else? Okay, moving on, I think Linda Graham, legislative report, please. And I would like to welcome Amber Walgrove. Thank you, Amber, for being here. You've made our day now. We can go to action.
All righty. So we finally have an end to our very long record-setting legislative session. And while some of what I'll talk about today is a lot of non-success in the world of public health, there were quite a few things that did come through, and I will try and do a follow-up report next month about some of the miscellaneous things that we really weren't on our priority list, so we haven't really talked about them. But I'll bring that to you next month. But one of them you'll hear about is some universal developmental screening. So in the upcoming presentation, they'll talk about some of that work that did happen. As for the legislative agenda, the stuff I had an update in your packet at the conclusion of the session. For the three major priorities that we focused on during the special session, the first one was e-cigarettes and vaping products. And unfortunately, we were not able to get any of that legislation through. There was both the regulatory piece and taxes. In talking with some of our partners throughout the state, we're feeling pretty optimistic that we might get the regulatory policy pieces through next year. That would include setting up license requirements for selling e-cigarettes and products, fines for selling to minors, and then a bunch of miscellaneous provisions like keeping the product behind the counter and things like that. So it's just setting up a regulatory structure very similar to how it is with tobacco products. The taxes piece, less optimistic about getting some taxes through. Certainly likely would not be at the numbers that were talked about this year, probably a much lower percentage if we can get that through. For marijuana, we were able to get funding in the budget, and so we have a little over $7 million for each year for the next 2 years. And DOH is currently working on plans for how that money will be split up between the various pieces that are called for. There's a statewide hotline. Then there's grants to local health jurisdictions to do prevention work. And a statewide media campaign. And the funding is actually for marijuana, tobacco, and e-cigarettes. So hopefully we'll hear soon about what kind of funding may come to us to be able to impact our programs. And on the coordinated prevention grants, unfortunately, we were not able to prevent the significant reduction that happened. That funding was cut about in half from what the previous levels of funding were. I spoke with David briefly about it. We don't expect to see a huge impact here locally. The funding for that program is given out based on population, and because of where the dividing lines are for funding levels, it really won't impact some of the larger population centers. It's really going to hit those kind of mid-size populations the most, so don't expect to see too much impact here. As for some of the other items that we worked on all session, I think the two significant issues, or three, that came through were some rail safety regulations put in place, and then also revamping of the medical marijuana market and some significant changes to the existing recreational market. Most of those have actually gone into effect. There's a couple that are delayed a little bit longer, but we'll start seeing some changes in those pretty quick. So any questions, comments?
Due to the fact, we have a better separation on the medical marijuana usage and recreation. On the medical side of it, are there going to be other regulations that this health board or health districts going to have to provide regarding the medical process?
At this point, I'm not seeing anything in terms of the Board of Health locally. I believe there are impacts on regulations such as City of Spokane's. You had some regulations around medical marijuana. So I don't know how much it's going to impact you.
It was mostly zoning, and it was also a regulatory license. And so we are still granting those for the time being, but we're warning folks that as of a year from now, it's done no matter what. So you will have to comply with be a 502 recreational medical business as of a year from now. So the current businesses that we have in the city are kind of operating as they are currently. Hopefully they're making plans for the transition. Yeah. If not, though, we will probably have to go the route of Seattle and do some pretty strong enforcement to make sure that they're complying with the new regulations.
Anything else? Okay, thank you.
Okay, thank you very much, Linda. Now to go to the consent agenda. There are two items on the consent agenda. The meeting minutes from June the 25th of 2015 and vouchers from June 1st through 30th, 2015. Anybody want to take one of those items off there for discussion? Or do I have a motion to accept them as shown?
Move to approve both items.
Second to that?
Second.
In conversation, discussion? Okay, at this point, all those in favor signify by aye.
Aye.
Nays? Okay, consent agenda has been approved. We now are going to be looking at the resolution 15-04 adopting the 2016 health history fee schedule. Mike Ryder, please. And Shelley, welcome. Shelley, welcome.
Thank you.
I was just going to be told by him to do that anyway.
Hi, this is Resolution 15-04, and this is asking to adopt the 2014 Health District Fee, which is a very important part of our budget process moving on into the 2016 budget cycle. And so the 2016 Health District Fee Schedule is one of the first parts of moving that along. And as you look through there, most items, there's been no change this year. We go back and we are using our current policy that we've adopted, I think, back in 2011. And so under that policy, we're trying to get 100% recovery in most cases. And so there's a lot of places where as they went through the fees, there was no changes, or there's even been some reductions in many places as you move through the fees on this thing. I did take the health district fee policy, or the fee schedule, to the Budget and Finance Committee, and at their recommendation, there was the paragraph 5 on there added that if there are some recommendations from the Board of Health Temporary Food Event Ad Hoc Committee that are accepted by the whole board, that those will be instituted into this fee schedule either before 2016 starts or if they happen during 2016. And so I just want to make sure that people know that that's in there, since that's been a topic of conversation over the last few months. And unless there's any questions on individual items, I ask for approval of the 2016 fee schedule.
No, Mr. Chair. The only thing I would add is our committee on the temporary food permit is at a point where I think we're close to a recommendation. We just couldn't meet the timeline for this meeting, which is why you see that in there, because we will be recommending a change to how the fees are currently done in that area. So with timing, we didn't want to slow down the entire process for them to move forward in working on their budget, but we will be coming back with a recommendation.
Okay. Any questions of Mike or Shelley at this point? Hearing none, do I hear a motion to accept the 15-04 adopting the 2016 Health District fee schedule?
So moved.
Second. Any further discussion? All those in favor signify by aye.
Aye.
Those against? Pass. Thank you very much.
Thank you.
Thanks, Mike. And Linda, you're back, please, on the strategic planning update.
I'll get back to that. All righty. So just want to give a brief update on where we're at with our strategic plan implementation. Under your governance responsibilities, the Board of Health is ultimately responsible for agency performance and ensuring that we are achieving some measurable outcomes. And our strategic plan is really a key element of that, both in terms of ensuring that we have a strong organization and functional work environment, but also in terms of setting some priorities of things that we want to carry out. So that's the reason that we had 3 board members participate in the planning work, and that's why we will be providing you some regular updates on where we were at. So you can really help make sure we stay on track with implementation and get to where we go, where we want to go. So just kind of a quick review. In the strategic plan, we developed goals and strategies, and then we got very specific in terms of action plans on how we want to carry out the work there. And so we ended up with 27 action items. And because there's no way that we can do all 27 at once, we broke it down into three tiers of priorities. And we will be focusing first on the Tier 1. These are the most essential ones. They are activities that other actions depend on, so they need to come first. And right now, Dr. McCullough is meeting with the leads on each of those action plans that are in Tier 1, making sure that they understand what their role is and what the plan is for moving forward. And then he'll be just checking in with them and meeting regularly. We also developed what we call an action plan tracker on our intranet so that staff can help keep track of where we are in the planning process. And what it has on here is it identifies what action, and then it shows who is responsible, gives the overall timeline for that action, and then the leads for each of those action plans are able to go in and enter updates so that staff can keep track of where we're at. And just a quick review in terms of what's in the Tier 1 priorities. As you'll see, majority of them that are in Tier 1 are in goal number 1. And that's the goal that's all about our work environment, really making sure that we're as strong an agency as we can be. And this includes the work that Tony referenced earlier about organizational development and leadership. So that's in there as well. And then there's just a few priorities or actions that are Tier 1 in the other goals as well. So that's all I had in terms of an update right now. Hopefully next time when we come back, we'll have a little more specific outcomes on some of those actions and be able to really report some more detail.
Keith?
Can I just ask Linda what the time frame is around the whole strategic plan?
The whole strategic plan's 3 years.
I lost track of that somewhere along the
We're
line.
looking at 3 years. Okay. Just knowing that kind of the world in general is changing pretty rapidly. Also, what we're hoping is that we can really make some great progress on particularly goal number 1, the work environment stuff within that time. So then we'll kind of free up our resources to then look at new goals and things we might want to take on. But some of these, the goals, there's some in there about equity and another one about developing some overall kind of community priorities work. even if we redo the strategic plan in 3 years, those things will still stay in place. We'll just look at a new set of priorities for particular focus during the next 3 years.
Dr. Lutz, would you want to add anything to that? Okay, any other questions of Linda or Dr. Lutz? I know you were involved, very much so. Okay, thank you, Linda.
You're welcome.
Okay, let's talk about Colleen O'Brien. Please, Colleen, on universal developmental screening.
Great.
And you have a helper today.
I do have a helper. Again, I'm Colleen O'Brien. I work I'm the program manager for the Infant Toddler Network and the oral health programs, the Access to Baby and Child Dentistry, and the Adult Apple Health Project that we're working on. And today I'm here with Heather Wallace, and we want to talk to you about just a wonderful campaign and project we've been working on called Universal Developmental Screening. And we've chosen the campaign is Ask Now, Babies Can't Wait. Both Heather and I work in the Community and Family Services Division. Elaine Conley is our director for 6.5 more days. So we're very happy about that. So in June of 2013, the Infant Toddler Network of Spokane Regional Health District and our local Universal Developmental Screening Pediatric Champion, Dr. Christy Rice, partnered with the University of Washington Great Minds and the Department of Health to host a community asset mapping project. The intent of the CAM event was to investigate in our early learning community who was conducting developmental screenings and what tool they were using to identify those concerns and see what those gaps were. We were very fortunate to have over 30 community partners join us that day. And in attendance, we had folks from healthcare, we had pediatricians, we had nonprofits, we had early childhood education folks, we had childcare workers, we had disability services, and early Head Start, and ECAP with early achievers. And of course, we had parents. So before the CAM was scheduled, one of the things we did was we surveyed and conducted a survey with 185 medical providers. This included primary care providers, nurse practitioners, case managers, and mental health professionals. And we surveyed them to determine the methods they use to identify children who may have developmental concerns or delays, barriers to completing developmental screening in their practice, and their knowledge of community resources to refer a child that has been identified with a concern or delay. From our survey, we learned that only 55% of professionals surveyed utilized a standardized screening tool in their practice occasionally, and 27% indicated they did not have adequate time to screen children. At that time, only 2 pediatric providers that we surveyed used a standardized screening tool routinely. The American Academy of Pediatrics recommends that all children receive developmental screenings at 9, 18, 24, and 30 months in order to identify delays and provide early intervention services as early as possible. So what is the need in our area? In Spokane County, 47% of births are paid by Medicaid. 23% of households are single mothers. Many of these women have high adverse childhood experiences, or ACEs, with 46 having 4 to 8 in their scores. Women with 4 or more stressors are 10 times more likely to have postpartum depression, less likely to have social support, and 6 times increase in low birth weight babies. These factors mean babies in our community are at risk for developmental issues. During the first 5 years of life, children are growing rapidly, physically, intellectually, and emotionally. This rapid growth and development provides the foundation for future success in school and ultimately in life. There is a wide range of ages for reaching developmental milestones, and children usually develop on a predictable path. However, some infants and toddlers may get off track developmentally. The Center for Disease Control, CDC, estimates that currently 17% of children have a developmental or behavioral disability, and 1 in 68 children are diagnosed with autism. That is a staggering statistic. Additionally, many children have delays in language or other developmental areas which can impact school readiness and, in turn, success in school. When children receive formal developmental screenings, developmental concerns or problems are identified early, resulting in more effective intervention and treatment. Developmental screenings identify children who have developmental concerns or problems that indicate a need for further evaluation or early intervention services. Screenings and assessments also give parents, families, and caregivers who work with children a better understanding of a child's strengths and needs. So two overarching goals came out of the community asset mapping process, and they are to increase community awareness of the importance of children getting early screening for developmental delays, and to increase the number of children in Spokane County getting timely screenings. You'd think with 30 people around the table, somebody had some funding that we could move this forward, but nobody did it that day. So SRHD took on the project, and we began to look for funding. Well, in March in 2014, a couple of great things happened. One, SRHD received a $10,000 grant from Providence Healthcare Systems to pursue the work of the Universal Developmental Screening and to develop a campaign. And two, utilizing combined funding, SRHD hired Heather Wallace, public health educator, to take the lead on the Universal Developmental Screening project. Together we worked with our awesome marketing team, Kim, Amy, and Najee, and we developed a campaign that would stretch the grant dollars as far as possible. Heather will explain phase 1 and 2 of the project, and I think you'll agree that SRHD did a great job using all the money that we had.
So I'm really excited to talk about this project, except I think I went up too many slides. There we go. Okay. So as Colleen said, we had a $10,000 grant, and we knew that we needed to stretch it as far as possible. And so to start with, we looked at what resources were already available in the community. We decided that there was no sense in recreating the wheel and spending resources to develop something that was already out there and scientifically vetted and available. So first we started with what are the resources available regarding development and developmental screening. So we looked at ESIT, we looked at the CDC, we looked at medical homes and great minds who were already focusing on the need for more children to be screened for developmental concerns. And we kind of packaged those materials without having to recreate anything. The other thing we wanted to do was make sure that wherever we were sending parents for information was also accessible and kind of consumable for parents. And so we did a website evaluation to look at who was offering this information and in what format and how accessible was it for parents. And so that kind of started the foundation so that we could create a campaign drawn off these materials that were already established. So in doing that assessment, we landed with Within Reach and their Parent Help 123 website. It's very comprehensive, has a lot of information for parents that are looking for some basics around development and what's typical for children. They also offered a screening tool. And as we had looked at the research around what tools are appropriate, what is the science saying are scientifically valid and reliable, we had determined that we wanted to work with the Ages and Stages questionnaire. And we chose it because it kind of came out highest in the rankings looking at what tools were available out there. And Parent Help 123 was already offering screenings through their program. And so it was a great marriage of those two, both a great website and also they were using a tool that we found really appropriate. And so what we did is we worked with Parent Help 123, and they actually, if I can, you know what, it's not going to let me link out.
It's not.
I apologize real quickly. I am actually going to go out to our other PowerPoint because I need the links live. Oops, sorry. Small technical difficulty here.
You need the full one?
I do. Sorry.
Nope, you're good.
So as we're doing this, we're actually going to show you the link real quick. One of the things that's great is that we were able to work with Parent Help 123, and their tech team developed a link that takes parents specifically from our campaign materials to the Ages and Stages link.
Here you go.
Thank you.
Without having to go through numerous clicks or look through information that wasn't relevant to them. And because we're able to do this, okay, come on, mouse. They're also able to track some data for us. And so on a quarterly basis, we are able to look at how many folks from Spokane County are utilizing this resource, getting screenings, and then we're able to follow up with those cases. So in our materials, as I'm going to demonstrate in just a moment, when parents go to that link, it takes them directly to this page at Parent Help 123. And so it was a great collaboration to be able to do that. The kind of the name of this project in maximizing these dollars has been collaboration. So we have a really awesome communication team here, and we sat down, we got the link, we a partnership with Parent Help 123, and then we said, okay, how do we make these dollars go much further than $10,000 could normally go? And so we were lucky to be able to produce a multimedia campaign. So the first goal was to make sure that more people in the community understood the importance of developmental screening, understood what typical meant, and that children, although they don't develop, X, Y, and Z on this date, it is a pretty normal, pretty typical route of development. And that if children aren't meeting these milestones, it might be important to take a look at those. So we created print materials, including the brochure that you should have in your packet, as well as we did a targeted mailing. We worked to send a targeted postcard to all parents who had had the birth of a child in the last 9 months so that they would begin to think early about child development. We did some web things and social media. We did a small campaign on Facebook. We also added a web page to our SRHD website, which has our campaign logo and the colors. We also wanted to make this really easy to accessible to parents, not a lot of distraction. From here, parents can once again link out to that Parent Help website, or they can click here for a brochure. There's also related resources, more information. So even if a child is developing typically, we want parents to remember that they can help their child grow and be successful by simple everyday activities. So there's tons of resources. And then, of course, what's really important is that they need to know where to go in case they do have a concern or their doctor has a concern about development. And so getting them back to our office. We also looked at the demographic of folks and families in the community to say what's going to be best, how are people going to most frequently see this information. And so we did a paid advertising campaign with bus placards, which ran for 5 weeks, and the estimated viewership is over 1 million views in the buses that we contracted with. And then we got the placards to keep so that we can use them in other formats. We also did a PSA, which we worked with the Nielsen ratings to determine when are people watching TV that have kids this age. And Naji helped us create a gorgeous PSA, which we're actually going to watch a little bit later. So once again, just the idea that parents can have access to this information in lots of different ways, and that the campaign itself is really consistent. It's really visual, it's enticing, it's fun. So a little bit about Parent Help 123 and why we partnered with them. One reason is that they are a statewide resource and we didn't have to pay for it. Since they are already doing this and providing great information, they also have a really good safety net in that when parents call in to get their child screened, there's numerous ways to do that. They can call in and get a screening. They can complete the screening online electronically, and then that produces a result. They can print it off and then send it in. And in any case, someone from Parent Help 123 will actually contact them to discuss the result, regardless of whether or not there's an area of concern or not. If there is an area of concern, then their direct resource is the Infant Toddler Network, and so those kiddos come back to us here locally in Spokane for services. So So this first phase, which was the media campaign, we had great success. Some of the FRCs don't want to talk to me anymore. We had such great success. So busy. So our first kind of look at this was how many people are accessing the information. We had over 1,000 clicks to the various resources that took them to the information. We had 17 children screened, and of those 17 children, 8 of them demonstrated a need that required early intervention. So that was 47%. Much higher than the estimated 17%, which means we're getting to the right kids. In our second quarter, we had 9 kids screened. 3 of them were referred for services, so once again, 30% of kids. Most recently, on our last quarter, as you can see, the media portion has kind of stabled out because we don't have the PSA running anymore, but we have a base of knowledge out there now. In the last quarter, 8 kids were screened. 50% of them needed services. And this is not the only way we've gauged what's been going on. And so the average number of referrals to the Infant Toddler Network for 2014, January to September, was 70. In the month of October, when the campaign dropped, there were 174 referrals for services. So it definitely made an impact getting that base of information out there. And then since then, we have not seen much of a decline. The average number, excluding October, has increased to 79 per month. But if you do include October, it's 89. And that overall increase is 27%. We've sustained 27% increase since last October for the infant toddler referrals. What's been really great about this is we've also been able to take the show on the road as it is. We were invited by the Department of Health to be their topic expert webinar in February, and so this was shared out with all jurisdictions in the state. We had 3 jurisdictions work with us to modify the materials for their own counties so that they didn't have to recreate the wheel. They were able to share their information with families in their communities. And then the project has also been accepted for a presentation for the Washington State Public Health Association conference in October. So Colleen and I are going to Wenatchee. So phase 2, since the first goal was to get the information out, have a broad base of information about the importance of early screening, early intervention. The second phase is to get more kids screened. So there are a couple of sub-goals under that, which is to understand what are the reasons why pediatricians are not screening. Why is this not happening in the office? What are the barriers? What are the belief systems? That sort of thing. Our plan was to recruit 4 pediatricians to conduct a pilot project where they would implement the American Academy of Pediatric recommendations of screening all children at the 9, 18, and 24 to 30 month, as well as 18 months for the specialized autism screening. And then track how that changes the referral pattern and the number of kids getting screened. So what that means is a collaboration. Dr. Christy Rice will be, she has been doing a training that was developed by the Washington State chapter of the American Academy of Pediatrics that is both the how to conduct the ages and stages questionnaire as well as how to implement that into a clinic practice. So she's going to be doing that training for us, and we will be working with the offices to help with the implementation process. The providers will get their nurses and staff to adopt the process, and then we will be evaluating the process both for the clinician but also for the parents and what those outcomes look like. And then the goal is that we replicate this process and all kids get screened. So we started our pilot, pre-pilot data. And so we have a couple of Rockwood pediatricians that have volunteered very excitedly to become part of the process. I'm having trouble kind of keeping up with them at this point, which is good news. So we did a 1-month look at WellChild Exams. So for pediatrician 1, the pediatrician conducted 79 WellChild Exams. So these exclude any visits for sick, any visits simply for immunizations or anything else. These are just WellChild Exams. The pediatrician completed one developmental screening in that month. They did 2 referrals, which were both requested by parents, and so then pediatrician 2 did 111 screenings and 111 visits and 0 screenings. He did have a number of referrals, once again, parent request. So looking at this, if we know that approximately 17% of children have developmental delay or concerns, we would have expected 14 of the Provider 1's children to at least be screened and referred for further evaluation, and 21 of Provider 2's children to be screened. So the good news is that we can only go up. We're hoping, we can get at least 100% increase. And the great thing is that the providers immediately recognized this is an absolute need and jumped on board. So we haven't had any pushback. In fact, we are going to see some great success. So where are we? I think I have. Okay, so that's where we are now. Where are we headed? So as Linda talked about, one of the great things that will actually help incentivize this is that the legislature approved and funded those AAP recommendations. So a provider must use a scientifically valid tool. So the Ages and Stages questionnaire is a great example of that. And they will receive reimbursement through Medicaid for the 9, 18, and 24 to 30 month and the specific autism screening at 18, and if there's additional screening required. So we are beginning our trainings on August 4th with Dr. Kablawi from Rockwood Clinic North, as well. Dr. Rada has also joined in the last 2 days after my slides were done. Dr. Grubb from Rockwood, Maine, Dr. Moorman, and Dr. Ashley Mickelson from Chaz. We also have 3 providers from Rockwood who are not officially part of the pilot but have agreed to immediately adopt the practices. And then Rockwood said, oh, what the heck. When we're done with the pilot, we'll do it organization-wide. So we already have one large clinic organization that has agreed to take it full scale as soon as the pilot data is gathered. So that's very exciting. We also meet with our focus group who informed this project from the very beginning every other month to look at what's going on for intervention service providers. How is this going to impact them once more kids are screened and we're identifying more kids that need treatment? And, of course, internally looking at what that impact looks like on our own ITN department. So we want to show you a few local stars. This is the PSA that was developed, and we have to give a lot of kudos to Naji. He worked with me and Pacific Park, the child care center that we had volunteer, to create this video. It's a great example of typically developing children, and it helps parents kind of put a face to what they should be looking for in their own children. So it's educational, but it's also, you can't help but smile.
Have you ever wondered if your child plays, learns, and speaks typically for his or her age? Here are a few milestones to discuss with your child's doctor. Concerned about your child's development? Ask now. Babies and kids can't wait. For more information, visit our website.
So the important piece of this project that's more than the pilot is looking at creating a norm change in Spokane so that all children are getting screened routinely. And so we will be working with Linda, our health policy specialist, and kind of what we're asking for the board to keep in mind is that We are hoping to eventually look at this from a policy perspective and look at the requirement of children being screened rather than just simply a recommendation. The evaluation and screening of children is critical to recognizing whether or not a child is going to have problems in development, language, speech, and whether or not they're going to be successful in elementary school all the way through adulthood. So, questions?
Yeah, there's been a lot of work done around the ACEs work. How does this mesh with that? Because it seems like there's some commonality here around things that happen to kids as well as this developmental process.
Absolutely. We know that ACEs and complex trauma actually affects the wiring and the neurodevelopment of a child's brain. And so a child who's experienced ACEs is more likely to have developmental concerns. And so I'm really lucky. I work with Colleen in this project, and then I work in the other side of Elaine's staff with Rowena Pineda and the ACEs team. This work really goes hand in hand because as we know more children have ACEs and we understand how neurodevelopment works, then the screening is even more critical to making sure that children are receiving treatment and making sure that we're working with families and physicians and others in the community about resiliency.
Thanks. John?
So this is, I guess, more of a comment for Linda. This is great, by the way. Thanks for the presentation. Very interesting, and it's great that we're going into that second phase where we may have a chance to spread these things institutionally instead of just via web response. But if we're going to go to a recommendation, that seems like a policy committee path. Excellent. Great.
Any other questions, John?
Yeah, I'm just curious, given your initial findings of providers not doing it, given your findings that of the two providers, again, the challenges, I mean, how do you help them? How do you facilitate it? I mean, pediatricians see more patients than any other provider in their clinics, and so there's sort of this obligate requirement to be seeing numbers, right. And yet they also know that the benefit, and so unless they have resources provided to them, they're not going to be able to carve time out of their WellChild check to do this. They need people to be doing it for them.
Mm-hmm. So, well, I was just going to mention that I think one of the things that we did here is that pediatricians were doing some kind of screening, but it really wasn't focused on with the ages and stages questionnaire, so to speak. And so the study that was done in Yakima, actually, they're the ones who kind of rolled out the ages and stages first in their community. They found that it was actually helpful for the time for the visit, because what it did is it focused the questions that the parents might have around specific things that they're seeing with the children. And so we wanted to educate the pediatricians about, first of all, it's going to help you in your WellChild visits or whatever, just so that they can have targeted conversations about children's development. So what we're hoping to do is have the pilot to show that this really was beneficial and then roll it out. Dr. Christy Rice has been trying to train docs around this area for about a year and a half, and very few have really jumped on the bandwagon. Obviously, having a little bit of incentivized dollars, too, to get the developmental screenings done will really help as well.
Any other questions?
Could I add a couple of other points? The Ages and Stages questionnaire is actually parent completed, and so the way that Dr. Rice and Providence Pediatrics have rolled it out is that it's done. They allot time before the visit for the parents in the waiting room, and the front staff are actually responsible for taking that. They have developed a great, fabulously creative, low-tech way of doing the paper version, because it can be done by paper or you can do it electronically online, or they can integrate, which is a whole other conversation. They laminated theirs, and so they use a grease marker, grease pen, and they just reuse them. And so, and then the nurse, they're done. It's a simple scoring. It's 0 to 5 or 10 on each point. So it's a really simple scoring mechanism. And then they just enter that score and any area of delay in the chart note. So the provider has all the information when they go into the room with the patients. So, and then, of course, the incentive of now being able to get some reimbursement for them.
Any other questions? Well, it sounds like it's very successful, probably because the two of you are working very, very hard at making sure it's successful. So thank you very much.
Thank you.
Next item, a board member check-in. So let's start with John. No.
Do you have a check-in?
No, you're first.
Okay.
I do have a check-in. I met recently with Alicia Spencer, who works for WSU, and they're recently in the recipients of a multi-year grant focused on the East Central neighborhood and health outcomes, and they're at the very early stages of kind of scoping this project, and I exhorted her to make as many connections and meet as many people at the health district as she could, and I think she's already doing that, but it seemed like an interesting project. Just wanted to mention it. And then I also got a phone call. I seem to get on every health district survey here in Spokane County.
That's because you're on the board.
I think it's also because I have a landline, which not everybody has. And this one was about activity or obesity and physical exercise, but I didn't get to do it because you're supposed to have a household income of less than $3,100 a month, and fortunately a two-income family were more than that. But I was just kind of curious to know a little bit of details about that, if anybody knows.
Was that from the health district or from the Department of Health?
It's a good question. I didn't ask. It may have been from the health department. So we don't know of the district that we're doing anything like that right now.
Yeah, not specifically from the district.
Okay.
Sometimes we partner with the Department of Health on similar things, but I'm suspecting that's a statewide survey.
Okay.
Well, perhaps somebody
Thank you
could
for
get
that.
back with John in regards to that information from the health district.
Yeah,
Okay, thank you.
But I was glad to see it though. I think outbound surveys like that are really valuable. So.
Keith? Susan? Shelley? Dr. Letts? Amber?
Well, I got to spend the morning with Rowena, another staff person here who was mentioned, I just wanted to compliment that the health districts is doing a great job really getting deep into the neighborhoods and working on projects with different parts of the county. The Zone is a project in the northeast part of Spokane, the city of Spokane, and we are actively working on developing strategies for long-term change to address poverty, economic issues, housing, health, and it's kind of being led, if anyone's heard of it, it's being led by, it's actually kind of came out of the school district, Spokane Public Schools, and they have a full-time person that the city is working with and other organizations to help fund to kind of catalyze this project. But anyway, I just wanted to thank the health district for their continued work. They have a focus area with the Neighborhood Matters project in Whitman neighborhood in the Northeast, and because of that, they've gotten really engaged with the Zone project, and I just really appreciate that having the health district staff at the table is always a huge benefit. They bring so much knowledge and understanding of not only the issues but the data and where we can find measurable measures to get to the outcomes that we want to see. So anyway, it's just wanted to make that comment. It's been really helpful to that project.
I do wish to make one comment. It seems like every day or every month as I serve on this board, there's more things that come up from the health district in a very positive manner and what they're doing. And I just think it's great. And so from my point of view, thank you everyone for that. Now, do I hear a motion to adjourn? Second?
Second.
All those in favor? Okay, adjourn. Thank you very much.